Meeting will be recorded and it's going to be posted on the council's YouTube channel. So a reminder to everyone that's speaking, ensure you switch your microphone on, it's the button in the middle, before addressing the meeting, and remember to switch it off as well when you have finished speaking. So we're going to start with apologies for absence. I've got apologies from Councillor Okereke and Taggart Ryan, and also from Jamie Carswell, Kate Heaps, and Andrew George from Oxley's NHS Trust, but I think he has sent, oh no, possibly not. He had sent a replacement, but they might be stuck due to the train situation, so hopefully Suzanne will be able to join us later. I think that's anything. Any other apologies? Can't see any. Brilliant. 2 urgent business, I don't have any. 3 declarations of interest. Do any members have any personal financial interest to declare in regards to the items on the agenda? I don't see any. Minutes. So, the last meeting, we took the whole session to focus on domestic abuse, which was a really great session, and a big thank you to everybody who worked to kind of pull that together. So we had some really good presentations from Dr. Charlene Knoll and Annette Wotton, and a good discussion that followed afterwards. I'd also like to particularly say thank you to the VCS organisations and the survivor of parental abuse who came and spoke to us as well, which was really valuable, and really appreciated them sharing their personal experiences with us. I found it really kind of impactful personally, and a thank you to the Her Centre as well for their insight. So we've reviewed, I think there was quite a lot of follow-up that has been captured in the minutes as well. The meeting, I think, let me see. So I think basically we have a sense of, I think there's work that the partnership can contribute that will really add value here. A clear sense of commitment among partners, and also really great work that was highlighted as well. So in response to the actions in the minutes, we've also suggested a health-focused task and finish group, which I think will be really helpful so that a smaller group of people can kind of work on some of that partnership piece and see how we can support joint working. And I think basically we will also ask those updates to come back here to the Health and Wellbeing Board so that you can have a further update on that. So are members happy to agree the minutes of the last meeting? Yes, don't see. Brilliant, thank you. So that takes us on to our kind of first substantive item. So today we've got a review of the emergency department attendances at Queen Elizabeth Hospital. So I think we have Sam, Joe and Kate are going to be presenting. Brilliant. So this item is bringing together several related presentations and discussions focused on urgent care, demand and health equity. So I think, without further ado, I will hand over to the team to present.
Public Health here at the Royal Borough of Greenwich. I don't know, Joe and Kate, if you wanted to introduce yourself.
Shall I go first? Hi, I'm Jo Sutcliffe. I'm Deputy Chief Operating Officer for LGT.
Hi there, I'm Kate Anderson. I'm Chief of Staff at LGT.
So as part of the prioritisation exercise that happened earlier in the year for trying to find priorities for the Health and Wellbeing Board to discuss, it was agreed that we would look at emergency department attendances by Greenwich residents at Queen Elizabeth. So we had various discussions, and we sort of agreed earlier on that we'd look at it through a population lens to see whether there was any particular populations that were using services more frequently that would suggest that real impact of health inequalities on the way that our services are used. So you've had the paper in advance, so I won't go through all of the slides here or all of the detail, but we will go through together some of the key factors that we've pulled out, and then we'll lead to a discussion sort of informed by Jessica's paper as well. So when we look at the attendances overall, you can see here that the numbers have stayed relatively static apart from that the COVID year of 2021, but the rest of them have kind of hovered around the 52,000 mark. So this is just for Greenwich residents' attendance at QEHED, so it's a sort of a focus bit on our population, but doesn't quite tell the challenge. But Jo, I didn't know if you wanted to tell about the context of how that works, because it looks, when you look at the data originally, you're just like, well, it's fine, nothing's really gone up, but obviously it's the context of how that's working.
Yeah, so that matches our internal data, which shows that it hasn't gone up, but we know that over the last few years, the number of patients that we've actually had to divert from QE to our partner hospital at Lewisham when we're at full capacity has increased. So Lewisham is seeing more Greenwich patients, which we might want to think about how we match that alongside this in terms of where our patients are going overall.
The other thing I'd just add is obviously this analysis is focused on our ED department. What it doesn't pull is people that have come to our UTC, which is co-located. So people that are not experiencing the significant kind of injuries or illness are tending to go to the UTC. And so it would be good at some point we'll look at that data alongside this so we can see those trends. And the other thing,
and just to clarify, UTC, Urgent Treatment Centre, yes. And is that the GP?
That's the GP run
on QE. Okay.
Yes, it's run by Greenwich Health, but it's co-located in the same area as our ED. And the other thing that isn't pulled through from here, this data is focused on patients that have got a Greenwich GP practice. And so if they've come from out of borough or out of area, then they wouldn't be in this data set. So just a few caveats before we get into the kind of the detail.
Thanks. So we did try to look for the UTC data in the data set that we have access to, but unfortunately they aren't coded to our being Greenwich GPs from the main provider. So we were unable to do that to back up some of the data. Anyway, by focusing on that sort of Greenwich residents, we can start to understand and match our population groups up. And what we really see when we look at the age of the people who attend ED is that the largest proportion, so that graph on the left shows the distribution by age of the number of people that attend ED. So that big grey chunk in the middle is our 25 to 64-year-old population, so that solid working age population. You can see that they have the largest number of attendances, but that's not surprising given that they have the largest number in their population as well. But what the graph to the right shows is the rates. So this is within those age groups, how many per thousand population do we get rates of attendances, which show by far that the highest rates of attendances are in our older population, and that increases from that 65, 74 up to our 85 pluses. And then you can see the 0 to 17 rate is also high compared to the working age population. And there's really a couple of things in there. So that if you're looking at numbers, when, obviously the desire is to decrease the number of people having to use ED, both because you don't want them to be in acute crisis, but also because of the impact that it has on our services, that the opportunity in terms of numbers is in those working age population. But actually, if you're kind of really trying to decrease where you've got the best opportunity to, it sits within those older age groups and the younger age groups. So that 0 to 17-year-old, half of those attendances are in the under 1 population. And we'll see in a later slide that population has the largest proportion of low acuity presentations and a different pattern of complaints. So the largest proportion of those people attending in that youngest age group are around things like fever, vomiting and breathing difficulties, which is very difficult for the ones that very different from the older populations, which focus more on chest pains and more difficult to get older. I'll just pass to Jo about the children's angle.
Yeah, so that's partly in relation to the model that we have between Greenwich Health and our main ED, where we've got an agreement with Greenwich Health that any child under 1 comes straight into the ED rather than going to Greenwich Health. So that's why you see those large numbers and why we need to see the two together to really understand. We don't see paediatrics as our biggest pressure, but it's useful to see that cut. The other thing just to say is this sort of the pattern of increased attendances as age increases is not a surprise. That's pretty standard across most EDs. But what's different about QE is actually our average age of our attendance is something like 47, which is quite young in comparison with some other EDs. So we've got that older population who do keep returning, but we've got quite a significant working age population who are using our services. And from our sort of insights in terms of those regular attenders within that working age cohort, a large chunk of those are coming with mental health or social care reasons, which is an area that we definitely want to kind of work on.
So I'll just take us back one. So obviously one of the things that we're always focusing on in inequality is to look at the impact of deprivation on outcomes. And what we found, unsurprisingly again, that you would expect to see, unfortunately really, is that the rate of attendance is much higher in those people from Greenwich living in the most areas that are rated as the most 20% deprived in the whole country. And that gradient right from the most deprived down to the least deprived, you can see around those attendances. And what you can see on the right-hand side is that looked at by age. So that gradient is really super stark for that older age group, so for that 65 plus age group. So the rates of attendances are 72% higher for our oldest age group in our most deprived areas compared to our least deprived areas. And there's a number of things that play into that. So we know that people who live in deprived areas are more likely to get iller younger, and so you have this combination of long-term conditions and difficulties that start much earlier on, and you can see that the gradient is there right from that youngest age group. That's coupled with sort of access to services and accessibility of services, particularly those planned preventative services and engagement with prevention in general, which then means that they're more likely potentially to access emergency care as one of their kind of default mechanisms to use services. Jo, is there Kate, anything you want to add to that? No. Okay, thank you. So I think what that really shows is that along A&E, it's absolutely an equity issue. This is like fundamentally front line, that you can see the inequalities that run right through those building blocks of health, from how we kind of grow, live, where we're educated and how much we earn. Tentacles hit absolutely everywhere, and through that burden of ill health, we see that right on the front line with our most deprived communities. We also looked at the analysis by ethnicity. So you can see there's the numbers of presentations by broad ethnic group, and then the little dots show the rates. So you can see by far that the largest proportion of attendances was through the white population group, which is not a massive surprise because it's our largest population, just over 50% in the borough, but also the skew of the age range. So we've got much higher numbers and proportion of older people within that right group. So when you couple with that data where we see that that older people are more likely to attend, that shows why we've got that higher rate. So notably there, that you can see the rates of attendances are lower for our Black, Asian and mixed ethnic groups, and much higher for our other groups. And the frustrating thing about other is that you don't have any more information other than their other. But we know that there's a reasonable Eastern European population that sit within that group. And so there's something for us really to start understanding about more deeper coding or bits of work to understand those ethnic groups, because it does suggest that they're using our ED in a slightly different way from other groups. And we did find there was an age difference too. Yeah.
Sorry, can I just check, how is that collected? Is that self-determined, or is it determined by the person that is treating them? And are those the only options?
So those will be the broad options. I probably I'll give a good guess.
I think it's self-determined. So you've got the option of updating when you come in, but it's not us deciding. It's people saying whether they want to declare or otherwise.
Recording's pretty good though. It was sort of around the 70-80%, which is good. It's enough to be able to feel confident-ish enough.
But when you go into A&E,
yep,
you don't fill in a form. So I'm trying to understand where you'd get that from. Is it from your GP record then, or?
So the data, it can go two ways. I think either if you've got it and it's on your spine record, it can be pulled up through the spine of the NHS, so that's the central NHS record, or it can be that they record it separately every time you go in, which is often what happens. It's repeated, or it's only asked once and it's in your hospital record, and so you won't be asked that after you've been to A&E once or you've had contact anywhere else. So you might not get asked every time, and it might be that they've pulled it up through national records, or that it's been asked by another bit of the hospital. So I'm just going to take us forward a little bit. The only other thing that we did look, so this is acuity of attendance, to see whether there was any difference, because there's been some evidence from different places around deprivation and ethnicity impacting how acute the need is when people appear. So this kind of, it levels out, so we don't see any different in deprivation, and that's because of the model of care, which means that the least urgent ones, you should only be getting the most urgent ones coming through to ED, but we do still see a slight difference by ethnicity. So Black, Asian, mixed and other ethnic groups have a statistically significant lower presentation of attendances that immediate resuscitation, urgent or urgent acuity. And so it suggests that they're being coded slightly less urgent, and that could be quite a complicated thing. It could be on presentation, it could be the way that we know that there are different ways and that people communicate about need that can be interpreted differently by different either the professional or the patient, and so but it does show that that coding's been happening, which would be interesting to explore a little bit more. So I'll take us to those chief complaints. So we have been lucky enough for the last couple of years to be able to do some linked data work. So we have data from 14 GP practices, and that gets linked up with LGT's data. And so through this platform called Healthy Intent, I was able to get some data from the ICB team to try and look at some of those background things that you wouldn't just know from hospital records. So what long-term conditions they've got, how many times they've also attended GP practice, to kind of get a bigger picture about what their background needs. The really interesting thing, because this is at individual level rather than the number of attendances, is that by far most people don't attend A&E at any time. So of those people that don't have any, sorry, I'm going to start again. So 10% of 10.7% of the practice population have one or more attendance to ED. So 90% of people don't ever attend ED. So it's a really specific population that is using that when they've got those really acute needs. That unsurprisingly really goes up to a third of people aged over 80 plus, because they have those needs, they're towards the end of life, it gets complex and they have acute things that need to be managed. When we look at deprivation, there's also a difference. So there is an increased number of people compared to the general population. So just over 12% of people in the most deprived 20% have any attendance compared to 10% and 10.7%. So it's not that much difference, but there is a difference there. But that disappears really when you get to the highest end, that deprivation doesn't seem to impact that multiple attendances as we go through. One of the things that we've been really looking at, particularly when we're thinking about the preventative work that's going on about managing things in the community, is the impact of long-term conditions. And from the data that we see, that there is no doubt that if you have long-term conditions, you're more likely to use services. So when you discount anyone who's got long-term condition, only 7.6% of people without a long-term condition are accessing ED. So it might be that people with long-term conditions are accessing ED, not for anything to do with their long-term condition, but that is the difference. And it talks to that age point as well. But when you get to people with multiple long-term conditions, sort of getting on for 50% of people with 5+ LTCs are accessing ED. So in general, the greater number of long-term conditions that you have, the greater number of multiple attendances that you're going to have with that. And you can see here, when we try to look at the different types, that things like heart failure that are likely to be towards the end when things are happening, and you have those multiple kind of crisis points, have the highest attendance. As one of the final bit of analysis that I just did was there to look at the relationship between ED attendances and general practice attendance as well. And so sort of always thought of being that if people can't get access to general practice, that they're definitely going to be going to ED. But actually what this rather complicated graph shows in general is that the more ED attendances that you have, the more general practice appointments that you have. So if you're using one thing, you're going to be using the other, and it's the mixture of the two. So that's sort of, there's only a sort of a small proportion of all of those attendances who aren't accessing GPs but are having a higher use of ED. It's completely the mixture of the two that's driving both activity using combinations. So people are trying to manage it through both ways. So I think when we come to, in general, sort of the key learnings from this and where there are potentially to have action is thinking around the children and that under ones. And I know that, I've been working in children's public health for quite a long time, and we've been trying to crack this nut for a really long time about trying to divert people through to other bits. Slightly complicated by the 111 protocols, where children under one are diverted through to emergency care if they need it. There's something about the ethnicity to do some further analysis with those deeper coding. But again, it comes back to the work that's all being done at the moment around prevention of really early on prevention around long-term conditions, mental health conditions, substance misuse issues, those things that drive that need for crisis care, and how we manage things in the community in that really preventative, holistic way. Jo, is there anything to
Yeah, I
add
was
there?
just going to add one other bit, I guess, in terms of that sort of the no correlation between GPs and ED. I think it would be different if we looked at the UTC attendances and ED, so that feels quite important. We know there's lots of work happening with Greenwich Health to try and shift those patients who could have gone to the GP or work out if there wasn't access, why there wasn't access, so that they're not using UTC inappropriately. But that feels like another important reason to kind of include this. And I guess the only other thing to say is in terms of sort of complexity of patients, we can see that across the board that our complexity is probably 20% more than it was pre-COVID in terms of all of our patients coming through non-elective pathways. So, and that's not just because we're doing more coding, that's because those patients have more complexities that are picked up. So it's definitely, that definitely sort of runs true with what's shown here.
I was just going to come in a bit more on the context, because I think I wouldn't want anyone to walk away from here thinking, well, you know, it's not very challenged, it's not gone up much. And I think I wanted to kind of just draw out that we know that the ED at QEH was built, you know, when the hospital was built, and was intended for a population that was significantly smaller. If you look at the investment across the borough, we have seen a real increase. And so where the ED was built for 200 patients a day, we regularly see across UTC and ED well over 400 and sometimes 500. So it is a really challenged space in terms of making sure that we get through all the patients. And I think it is one of 3 boroughs in London that have, well, one of 3 EDs in London that serve 2 boroughs. So if you think about it, most boroughs have an ED within them. ED at QEH is serving a lot of Bexley as well as Greenwich. So if you look at its footprint of where patients are coming from, it is very large. And what we see when we look at the data is that actually it is one regularly in the kind of top 5, top 10 busiest hospitals in London. If you look at what's coming into that ED in terms of ambulance arrivals, blue light arrivals, it is a really hot site and amongst the busiest in the capital regularly most days of the week. So I think just wanted to kind of bring in that. We've not looked at any of the performance data here this morning. So, you know, I think we would recognise that we know that performance isn't where we want to be on the 4-hour waits, on the ambulance handovers, on the 12 hours. And I think that's something maybe we can bring back and have a further conversation on, because I think that's where we would look to partners in the community across, you know, South East London to help us with some of those challenges in making sure we create the right pathways for those patients coming in through that front door. So just kind of wanted to just set that against what is really, really a helpful analysis and gives us some really helpful information to kind of digest.
That's really helpful, brilliant. And I think that's because we've got more sections to this, so apologies. We won't take questions now, we'll keep going because I think we've got other presentations and then we'll take them at the end. So section 2, we've got admission avoidance, and I think Jessica Arnold's going to, so if you can introduce yourself as well.
Thank you very much, Chair. I'm Jessica Arnold. I'm the Director of Primary Care and Neighbourhoods within Greenwich ICB, and this does segue really nicely from the previous item and a few things I wanted to pick up. So with the change of government last year, the Secretary of State commissioned the Darzi review, which colleagues will have heard of, maybe be quite familiar with, that looked into, in a lot of depth, into the state of the NHS, the state and the long-term viability of the NHS. I'm not going to go through my slides, actually, so it's okay for information, and I'll talk to what they say. From that review, Darzi identified 3 key shifts, and the one that I really want to focus on today and go into some depth around what we're doing in Greenwich is around from hospital to community. So colleagues have talked really eloquently with great slides around the data, the quantum of demand for ED, the complex dynamics around age, deprivation, ethnicity that lead people to use ED or indeed not use ED, and around some of those drivers. It's a great idea to come back and talk about performance, etc., and how we can do better, but ultimately the best way to reduce the demand on our emergency department, help the hospital and improve performance overall is to provide care in the community, so in everything but hospital settings, and that's what Darzi's kind of go forth and do instruction was. So we've been thinking for the last couple of years around what this looks like on quite a tight geography and a tightly held geographical basis around the neighbourhoods work, so I'll say a little bit about that. But it's the providing care in primary care, so not just general practice, the two often get conflated, but pharmacies more and more, and increasingly thinking about dentistry and optometry as well as places where perhaps you might think about more than just your teeth or your eyes. So opportunities there, and thinking about other community-based care services that keep people out of hospital, not just having those services and having them available, but making sure they are accessible, that our people, Greenwich people, are willing to use them and they're comfortable with using them, and they're high quality as well. There's no point in having community services if people then go into hospital. You're just adding a layer. So we need to make sure they're efficient and high quality to reduce that demand. And of course, timely. Same thing really in a way. But we can have great services. If you've got to wait 6 months, 12 months for them, depending on your condition, you'll end up in hospital. So we're doing lots of things around it, and I wanted to be succinct. The slides have been put together by colleagues, and hopefully people in the room have had a chance to have a look through them. I think what we're doing around the shift into primary care from hospital into the community and primary care fall in 6 categories, so I'll go through those. Firstly, having a really good general practice offer in Greenwich. We've got 29 practices. As in any borough, there is variation in accessibility and care and how patients use those services, but we are increasingly, both through local and national opportunities, trying to increase access. So the number of appointments that we've provided is higher than it's been in recent years. It's a misnomer out there publicly that you can't get a GP appointment. You can. There's a wide range of ways to access the GP as well, the GP practice, not just with GPs, but through pharmacists, nursing, of course, and others in the practice that will help to holistically think about patients and not just offer the bog standard appointment if that's not going to be what that person needs. Extended access as well. This isn't something new. Extended access has been general practice for a while. In Greenwich, 6 of our 7 PCNs meet the extended access requirements, and the 7th offered 2,000 additional appointments to what they had to do, so they're surpassing it, and that's in the Eltham part of the borough, so thinking about the data around the demographics with older people over 80s using health services. And our social prescribing function as well. So we're looking at this at the moment. I'm sure it will come back to Health and Wellbeing Board at some point with commissioning changes and thinking about how we don't just medically treat people, but going back to the dynamics around deprivation, ethnicity, age, etc. Really thinking about what does this person need to stop them going to hospital, to stop them having kind of deteriorating conditions. In pharmacies more and more are delivering health services as well. So we've got 57 pharmacies in Greenwich. We know from COVID that there's many groups of our population groups and community groups who prefer to go to the pharmacy and will go and into the pharmacy, not necessarily go to their practice at all. So the delivery services, and most of those are signed up to the new Pharmacy First scheme, where they can directly provide care for 7 key conditions that don't really need to go to general practice. So again, we're working closely with our pharmacies, but have plans around doing that more so. Secondly, in the community, we have our, I'm not going to use any 3-letter acronyms, so we have our urgent community response, our joint emergency team, basically our virtual ward, keeping people who are quite unwell at hospital, quite nervous to speak about that in front of Dr. Yogaraja, because of course you work in that service, so you may want to comment. So there's that work there, and also care homes, so people who are unwell in older categories, keeping them at home or in the community or in their care home, will again be looking at those enhanced care arrangements around care homes particularly, but also looking at learning disability care homes, looking at extra care housing, sheltered housing, etc. The step before people are pretty unwell and needing care in nursing homes. Thirdly, we have a really strong primary, community and secondary care interface forum and programme in Bexley and Greenwich. So really good point, Kate. I was going to make that point about Bexley patients using our hospital, not using our hospital, that's a terrible way to phrase it, using the hospital we have in our borough, here within Greenwich Borough. We've been doing some really productive work over the last 18 months around those interfaces, because again, if the interfaces relating to urgent care don't work in the system, the patient gets lost, they give up, they go down the path of least resistance. So we need to make sure that that's as good as it can be, particularly with the same-day emergency care service that colleagues, I say colleagues at the Trust, but actually the point of the SDEC, the same-day emergency care, is that it's the in-between, the intermediate, so it's not going into hospital as such, even though it's physically there, but it is around that potential step up from primary care, but less acute. So that's all in the pipeline at the moment, and we'll continue working on those interface issues to make things run as well as they can. The UTC has been mentioned as well, and the data doesn't break down in the same way, but we do know, exactly as colleagues have said, the UTC is a port of call for people who are either not able to get into their practice or perceive that they're not able to. We know that there's appointments out there. I've been literally stood with GPs who said, I'd be mortified if my patients are in the UTC because I've got capacity today, but we know that that's not always, people don't necessarily think they can. They maybe had a bad experience 12 months ago and then just go directly to Queen Elizabeth. So working closely with the UTC. And then two final points I wanted to mention as real opportunities to go above and beyond some of the things that we've been doing and that now present themselves at a particular place in time with this emphasis on the shift from hospital to community. One is the development of proactive care pathway for patients in Greenwich. So we already have a frailty service. It's a good frailty service, but it's not well used given the demand. We are looking to expand that to care for not just frail patients, and certainly not just severely frail patients, but those moderate or even mild frail patients who are at risk of escalating, but also people with complex long-term conditions as well. So having that proactive care to systematically identify people who are at rising risk of deterioration of their healthcare, high levels of use of the NHS and ED attendance, and to work with them on not just their medical problems, but around their wider well-being, and introduce a strong sense of well-being coaching, of social prescribing, and having that kind of holistic conversation with them about their health conditions and their carers, of course. So that's in the pipeline at the moment. That will be a core part and certainly an early part of our launch of the neighbourhood health service, to use the national phrase, that we're developing in Greenwich and making that tailored to those geographies and to those areas. And then finally, an opportunity which isn't Greenwich specific, it's across South East London, but we are reprocuring our 111 services as well from the work that I mentioned with the interface group and really looking at the dynamics of where patients are going. We know 111 doesn't work that well for ED, it doesn't work that well for general practice. Lots of GPs say about wasted appointments or patients kind of being booked in when they're not sure why they're there. So we need to tighten that up, and the best way to do that is to have a really kind of Greenwich-based specific approach to that service, to make sure that when a person's picking up the phone or going online to 111, it is helping them to get to the right place and to be kind of perhaps more part of that system and the dynamics of that system than it has been, given some of the difficulties. So I talked for longer than I thought I would. I've chunked out there into those 6 areas and talked a little bit about that shift from hospital into community. So I'm very happy to take any questions.
No, that's great. And I might jump in with mine and give people a few moments. Thank you for everyone. That was really, really interesting. On the UTC data, it kind of, you talked about, is there basically any kind of information sharing across the UTC and the GPs? So if there is, for example, a certain GP or a certain PCN that has a high level of presentation there, you can have conversations to explore that. Okay, people are nodding, but if you come back if you have anything more on that. The other one was, with the frailty service, is it, what's the referral like? Can you self-refer? Do you have to be referred by a GP? And could you speak a little bit to the under kind of utilisation and how we think that we can improve that? And I guess a wider one that across kind of, you've highlighted those kind of two groups, like children's and older people piece. So it'd just be interesting kind of, I know that Jessica's spoken to a lot of that work that's going on, but is there anything more particularly for this partnership of how we can work together for more of that community piece? And the other thing I wanted just to flag was that the scrutiny panel are taking age-friendly borough in January. So I think it would be interesting to think about maybe the question, we'll be presenting a report, but also it might be worth considering that there might be a discussion there about what services older people are and aren't engaging with in the community, potentially. But yeah, just putting that out there. But yes, a few.
Add a few bits, if that's okay. We've been thinking as well about the shift left and what that means and what we could do to influence that from within the hospital. And Ben, our chief exec, is kind of coming up with a proposal to take somewhere. So it's just in that context, he's looking at how we know we're going to spend money this winter on boarding patients, which is putting patients in ward areas that aren't meant to be for patients, just to be able to accommodate everybody. If we're going to do that, could we spend that money better, and on what? So these kind of things are definitely the conversations that we're having, and some of the things that have come out of that are things like care homes at weekend and whether they've got enough medical cover to allow us to move patients home at weekend, those sorts of things, or bloods in the community and whether the right sorts of services are there for us to discharge a patient who can get their bloods done tomorrow rather than keeping them in for an extra day. So there's lots of potential there, and our team are really keen to kind of continue having that conversation. I guess the only other thing to say is from our perspective, there's a lot about knowledge of what services are there, and there's a lot about risk aversion from our clinicians within the hospital, which is not going to be met by us just putting the services out there. So how do we make sure that teams know about what's there, and how do we build their confidence in what's there, is a really important part of what we need to do from our perspective. Otherwise, our team assume that there isn't a safety net, and they'll want to investigate further and bring patients in. So it's really key that we keep talking.
Then if I come back to some of your questions, Councillor, yes, the UTC data does go back to GPs. I think that's different from GPs having necessarily the time and capacity to sit and analyse every person who's been and where the pathway could have been. I think with the proactive care pathway that we mentioned that we'll be rolling out later in the year as part of the neighbourhood working, that will flag up people who are at higher risk, and some of that might be because of their conditions, but then in assessing that person and what they might need, we'll look at urgent attendances. The frailty service isn't self-referral, it's referral through a professional in the system, and the underutilisation. So the way that we are keen to increase utilisation of not just that service, it will become the proactive service. Firstly, we'll be putting into the GP contract locally with a pretty generous incentive for practices to have to meet a certain threshold of referrals, because I refuse to believe that in any practice there aren't people with long-term conditions or frailty that would benefit. So it is about bringing up that variation to meet that need. We are also looking at some of the data platforms and tools that you can use to find people. I think many practices would say we know who our patients are that we're worried about escalating poor health, and they probably do. Probably their receptionists know about them, let alone the medics. But what about the people who aren't going into the GP practice, who are going into hospital, or maybe aren't using services very much at all, but have got some really quite serious conditions? So we're looking at increasingly sophisticated tools across South East London, Greenwich or otherwise, to improve that identification, and then making sure the right people are around the table. I think in the frailty service at the moment, the right people are around the table. There's some great input, but the system is set up with a focus on medical, and then the kind of well-being is an addition to that. That's great. For some people, the main thing that they need isn't necessarily a prescription or to talk about lifestyle, etc. They need some practical help, etc. So really beefing that up will help. And then just your final question there around children's being a focus group, a group of focus, sorry. We have a local child health pilot happening in the west of the borough at the moment. That's yielding some really good results in terms of providing care in the community for children with their parents for a number of different conditions. The data coming through from it is still quite new, so obviously in the sense of a pilot we will see where that leads to, but it is our aspiration that through the neighbourhood health service model we're then able to replicate that in the other areas to provide some really kind of robust care for children as well.
Any other questions? Yeah, Nupa and then Gabby.
Thank you, Sam and Jessica. It was just a couple of comments. So, Sam, you helpfully presented the data around the deprived groups and ED attendances and that inequity gap. And I wondered if the data had been triangulated for those patients with their GP data as well. So I imagine maybe a lot of them are not registered with the GP, but I also am intrigued to know whether they are presenting at general practice in a similar way that your high intensity users are presenting across both services. So yeah, I was just interested to know about that triangulation. And Jessica, just thinking about the proactive care pathway, one of the pieces of work I've been involved with LiveWell was in a high intensity user pilot. And I spoke to the National Association of Primary Care when we were setting that up. Because we no longer had the patient activation measure tool to use because it had been decommissioned by the NHS. So we were looking to find a way to measure how empowered or confident people felt after they had had their sessions with LiveWell. And they signposted us to something called the Magic Question, which is based upon the patient activation measure. It's much shorter and snappier. And the LiveWell team have found it really useful because it essentially gets patients to grade 1 to 5, how confident are you in managing your own health? And then 2 is, well, what can we do to make you more confident? And they've seen some quite good progress. But the other helpful thing is the NAPC have actually managed to look at it as in if you move a point up, this is the amount of savings you make across the service. So that's quite helpful, I think, when we're thinking about commissioning. So if you'd be interested in how that could maybe fit into this pathway, yeah, maybe we could pick up that conversation because it will be good to see it being used more as well.
Should I come back on the other point? Or yeah. So I just wanted to pick up something. Just one of the things that you mentioned, Councillor, was around the age-friendly borough and the older people thing. I think that's so important. I think we sort of slipped into this bit about older people, like in this deficit bit that they they get really ill and they keep using loads of services. Actually, ageing should be like super positive. And how do you support? How do you prevent and make that kind of? I mean, I'm really looking forward to retirement. I hope I'm well enough to enjoy it. So I don't like. How do we do that to think about that more positively and wrap around it, but support people when things don't go so well? So I think that initiative dovetails really nicely with this, that you can do things along the positive around of supporting, and I think the work that's being done is largely around that positive bit, but bringing those two bits together I think is a really good thing, and making those links super explicit. I think the ED attendances bit, no I didn't, and I'm going to honestly say it was off a BI dashboard and I would have been there for about 3 years if I'd had to click through every GP practice with deprivation, but I do think it's an interesting bit. I did look at GP practice with the healthy intent data because I had that pulled out essentially in a way that I could analyse it through that, and there were significant differences, and I did look at that by deprivation actually. So yes, at the fewer attendances there was quite a significant difference between some of the practices actually in terms of how they managed. Some of that was accounted for by care homes and things, which was the largest bit, but there was a little bit of difference, and there was definitely patterns in there between some practices who had quite significant more ED things. But yeah, so I did actually look at it, but in a slightly roundabout way that we can have a further look. But I do think there's a question in general about how practices, on top of everything else, and it just seems crazy, but get that population level data about who their people are, what that means in the round, and what the different outcomes are within that. And that NAPC question about that sort of what matters to you confidence can be so helpful and take you in a different direction that you might not have gone on before, and gets to that real heart of actually what will make a difference to you. Yeah, thank you.
Last one, just thinking of LiveWell, it would be also good for us to be thinking about how we can kind of match some of those over presenting groups against our Liverpool data and just see
Yeah.
what we can pull out of that going forward in the future.
So it's been a big gap, I think, to this point. So we get some bits of data through, but it'll be absolutely at the heart of the new contracting and the way that we've recommissioned to put equity and manage looking at health inequalities really intentionally and actively to see how you change your offer to reach the people that we really need to.
Oh, sorry, Gabby. It was Gabby next. Apologies.
No, thank you. So I just wanted to come back on your point, Kate, around basically the infrastructure at QEH and it having been built for a significantly smaller population, and just whether there was anything that was possible to say in the kind of medium long term about the site and whether you see that or how we see that kind of being developed.
I'll have a start and then might pass to Joe. So I mean, the site is challenging, and I think we've known that for a while. And if I'm honest, I don't think the stuff that we are doing, we are building an additional ward now that we're hoping will give us capacity. But the reality is that however much capacity we were to build, we'd probably fill it. And so I think we are thinking slightly differently, in line with the 10-year plan, in line with the shift to community. We've got to do something different, because if we keep doing what we're doing, we're getting busier and busier, and the service that we want to be able to provide to patients can't be provided. So I think there is a real need to think outside the box, to look at what is possible. Obviously, we've put in, we're doing quite a lot of work at the moment, and Joe will be able to talk about this a bit more on our front end. So looking at what we can do, we've put in SDEC models 7 days a week for the first time in the last few months. We're really kind of trying to think, but we need to think more and think harder and look at what we can do with partners to try and address the challenge that is not going away. I mean, we're very conscious that, we've got all the data, we know all of the investment in this borough, which is brilliant. We've got all of the additional properties in Thamesmead and Kidbrooke, wherever, they all need access to health services. And the reality is we're not going to build a new hospital anytime soon that's going to be able to kind of absorb all of that extra need. So we've got to find a way to manage it. But certainly there are lots of things that we are doing to try and invest in the site, redevelop the site. But that alone wouldn't be sufficient. We need to provide care using different models. Joe, have you got anything?
Shall I add? So we've done quite a lot of demand and capacity work over the last year to really look at why are we in such a pickle. And actually the size of ED, the size of the emergency department, is big enough for the cohorts of patients that come through. It's those patients that are in the ED waiting to be admitted that are filling the space. So it's the bed shortfall that we've really got a shortfall in. There's two things that are coming online over the next year. So in November of this year, we're changing the model for 80 of our beds to become an acute medical unit, which is just a different way of working. At the moment, those 80 beds have an average length of stay of 5 days. We're really boosting the staffing to increase the turnaround of those patients, increase the speed of diagnostics and decision making to make it more like 2.5 days or 3 days. So that will really help us with capacity. And then we've got a whole new ward coming online probably this time next year, hopefully it's a little bit sooner. With those two things, and with a programme that we've got across the boards to really work on the things that are within our gift in terms of managing length of stay, that moves us from a deficit of something like 90 beds to something like 15. So that feels a whole lot more comfortable. And then there's the work that we need to continue doing in terms of discussions and work with all of our partners. So on any given day at the moment, we've got something like 60 patients who don't need to be in a hospital if certain things could happen to move them on to where they need to get to. So that piece of work will obviously help us loads to move things forward. So there's that bit. And then estates-wise, this year we've got some money from NHS England to help us in the short term. So there's three things that are happening this year. So one is improving the streaming space for when you first go into the urgent treatment centre. At the moment, it's not a dignified space to be talking to people in. That will now be defined spaces where you can talk. The second is to improve our SDEC space, giving more clinical and better waiting area space for that area. Same day emergency care. Apologies. So that's, I think Sam talked about it. That's that. Oh no, just Jessica. That's a cohort of patients that need a bit more than just something in ED in the emergency department, but don't need to be admitted. So all of the services wrap around that. And then the third thing for this year is in our paediatric emergency department, we've got a fit-for-purpose sort of mental health space being kitted out there because we have ever-increasing numbers of those sort of, teenager patients with significant either diagnosed or not diagnosed mental health needs, and we want to keep those people safe. So there's quite a lot happening now, but there's also this sort of view for the next couple of years of how we could make it better.
That's great. Thank you. Nick.
Thanks. I think really helpful presentations, and my reflections were going to be picking up really on what Joe had said there. There's a couple of things I think you picked up earlier in the presentation about the social care needs of people coming through at into ED, and I think that the work that we're doing around the sort of neighbourhood models of care and how we might have some more multidisciplinary team working, I think that it exists, but actually some of the sharing of information around our people that we are commonly dealing with, be that in Live Well or be that in adult social care, is a real opportunity, not just in terms of getting the data out, but looking at how we work in multidisciplinary ways and change our practice in order to meet those needs, both in terms of taking pressure out from the ED, but also in enabling people to live more independently for longer. So that was one reflection. And then I was just picking up, Joe, on the point that you'd made about some of the changes afoot, and I think there's obviously been the investment of some of the 106 funds into the front door to support that streaming work, but also the work we're doing on our transfer of care hub, as we're calling it, and that's across Bexley and Greenwich, and that's been a piece of work that I think should make a difference in terms of the 60 people you've described who at any one time are in the hospital. So I just wanted to overlay those points, really. Thanks.
I don't think I see any more. No, that was really interesting. I think it feels like potentially that part of the follow-up, one for us on, I think, age-friendly borough, like how can we take some of this learning into that and look and, you know, involve colleagues on that kind of what are the access issues potentially around the community piece. And I think one of the things I think I've been trying to find out is like how you know what services do we have and are older people well served to keep fit and healthy to then hopefully support them as healthily as possible in their old age. It would also, the Live Well piece again is one for just for us to be mindful of. The other one I would like to ask, but I feel like it's probably near impossible, is the ethnicity. I don't know if you could. Is that the best it can be? Is that like a nationally defined piece, or can we go a bit further? As in, it did seem like there was quite a lot unknown. Doesn't seem that helpful, but I'm not expecting any responses now. But please let me know if we can improve on that. It just feels like it would be great if we could, and I think we could do more with it. But I understand that might be a lot more complicated than I hope. And then, and the last one was, I think, the point about if we could bring together the UTC and the GP data at some point and kind of triangulate. And I think also the suggestion about the measure that you talked about, I think would be, if that's something that we can explore. But I don't know if there was any other suggestions, recommendations that we can look at. Catherine?
It was just on the measures point, really, and obviously we can talk about it further, but there is a commitment from the kind of prevention interventions as well to really be getting consistent with the well-being measures that we're getting from things that we directly commission or have through grant allocations, but also to support the sector to be doing those measures as well. So I think there's just a big picture there that we can maybe try and dovetail together a little bit. So happy to explore that further.
That would be great. Thank you. Great. I think thank you very much, everybody, for your contribution for that item. I think we're going to be moving on to the next. I just wanted to quickly say well done, Susan, for battling the trains today and for joining us. So I'm glad that you were able to join us. So next we're moving on to item 6. So we've got the review of anti-racism for health equity community of practice. So I think I'm handing over to Nupert and Catherine, if you can kind of introduce yourselves. And Ultimately, this item is focusing on the borough's work to embed anti-racist practice across the health and care system. And they're going to be taking us through how the community of practice is supporting this ambition. So over to you.
So thank you very much. For those who don't know me, I'm Nupur Yogaraja. I'm GP and also the clinical lead for Be Well, which essentially is a big focus on population health and health inequalities. And I work across the ICB and public health. And Catherine, did you want to introduce yourself?
Hello, yes, I'm Catherine Hannafin. I'm the Associate Director in the Public Health team around neighbourhoods and inclusion.
So this morning we were going to take you through the Anti-Racism for Health Equity Community of Practice. It's a real mouthful, so I'm going to refer to it as COP as we go through. And what we wanted to do was really show you the roots, where it started from, what the thinking was behind it, and that's been just over a year and a half, and take you to where we are today and what we've been doing in that time. That's the team there, so myself and Catherine have obviously just introduced ourselves, but it's really important to acknowledge our other three members because we wouldn't be able to do this work without them. So there's Kelly Ann, who is a Senior Public Health Manager, Alexia Fergus, also Senior Public Health Manager, and then we've got Vicky Smith, who works, again, Public Health Manager, focus on inclusion, and all those portfolios are broadly in equity, neighbourhood and inclusion. So that's the team. So a lot of our thinking about why we came together, why did we even need a community of practice? So we were looking at various bits of data. I know for lots of you this data will be quite familiar, but we were collating really different types of data focused on ethnic health inequity, what was happening in our borough, what's happening in South East London. The data I pulled out here is more recent than what we looked at a year and a half ago, but actually is very similar in terms of the picture. So this is an example of our patients with chronic obstructive pulmonary disease and the uptake of the flu vaccine. And what we were seeing there was a really a disparity in the data between our black residents, who had an uptake of about 41% compared to our other ethnic groups, like our Asian groups, and our white groups. And of course, we worry more about patients with COPD from the perspective of flu because they're a lot more likely to be hospitalised, end up in ITU, need artificial ventilation. So, you know, we were seeing disparities such as this. And Catherine, if you don't mind moving to the next slide. So that was an example of flu and COPD. And again, we see this persistently in our hypertension, our high blood pressure data. So this is our Greenwich data. So if you look at the prevalence of hypertension, so these are all the people that are actually in their GP record coded as having hypertension. So they're the ones we know about. And what you can see here is those from a black ethnic group, we've got 17% prevalence there. So our highest. And if we look at the next slide, which is, well, what's the control? How well are we doing from the perspective of controlling this high blood pressure? And we have clinically driven targets that are evidence-based, and we want to match those because we significantly decrease the chance of having consequences such as a stroke or a heart attack. And what we see here is about a 10% difference then in control in our most controlled groups, so our Asian and white groups, and then our black ethnic group. So a real difference when we think of the prevalence versus control. This is actually a national picture, so it's not just our borough, and it's a persistent picture. So it's probably quite important for me to add that in. So, you know, this is the kind of context of where we were in our thinking, that, you know, we were seeing lots of great front-ended interventions happening, targeting these various communities, whether we were looking at encouraging flu vaccine uptake or blood pressure checks or encouraging people to see their GP to get their blood pressure under control. But one of the things for us is there seemed to be something missing within the system about how we approach ethnic health inequity, because we were doing lots of front-end work, but where did it come from in the first place? So there felt a bit of a gap. So that's just a bit of a context with the data. And then on the next slide, what we can see is, you know, well, why does it matter? This is the last bit of data I'm going to show you, I promise. I quite like data, but I appreciate it's not everyone's bag. And, you know, this is a South East London snapshot of our blood pressure control. So again, the people we know that are registered with their GP, there's lots of them we don't know about. So before COVID, we were controlling about 70% of them. We took an impact which was expected, but we're still not back there. We're still about just over a percentage point under where we were. But the real important bit, and Catherine, if you wouldn't mind clicking, because it will highlight that box, is if we moved our control to 75% of those people, we start to prevent, this is across South East London, 86 heart attacks, 128 strokes and 68 deaths. And if we move it even further to the 85%, sorry, Catherine, you know, we go to 230 heart attacks, 343 strokes, prevention of nearly 190 deaths and 5 million savings across South East London. Now, this really demonstrates we need to do better for everybody, all of our ethnic groups, our whole population. That's very clear. But what's going to be quite obvious here is because we've got that real disparity in the blood pressure control of 10% between our black ethnic groups and our other groups, they're going to take the brunt of those heart attacks, those strokes, and those deaths. So, you know, I think for us, the picture was really building around needing this focus on ethnic health inequity. And Catherine, would you mind moving us to the next slide? Thank you. So in that sort of, well, why is this happening? You know, where are the gaps? We started to do some more deep dive work. I think the diagram on the left, lots of you would have seen the social determinants of health. So we started to consider, well, what does it mean in terms of race and inequity and discrimination in terms of social determinants? And of course, with our rainbow model, as it's commonly called, we've got the biological and genetic factors we're born with. We can't control those. And then as we go outwards, there are all the things that have a huge impact on our life as we go through it. Our physical health, our mental, our social, our emotional health. So individual factors, social and community networks, you know, how embedded are you? How isolated are you? What's your educational opportunities been like? Your employment, you know, we know even things like 0-hour contracts have huge effects on people's health outcomes. Your access to good, nutritious food, the general kind of socio-economic and cultural environment you're in. And then during COVID, we saw patients from global majority backgrounds a lot more likely to end up hospitalized or in ITU or dying with COVID. And so some public health colleagues went away and said, well, where does racism and discrimination fit into that model as a social determinant of health? And what they surmised was, well, it doesn't actually fit neatly into one layer. It becomes very pervasive in terms of how it affects your health. So from discrimination and stigma to considering institutional and structural racism. And they kind of completed the semicircle and made it a circle. And so this was sort of shaping a lot of our thinking over where's the gap? You know, what is it additionally we need to do other than these great front-ended interventions? Catherine, would you mind just clicking on? Thank you. So again, delving a bit more into, well, what are other people doing? What is the literature telling us? Well, it was actually, we were probably going to need to move to a bit of an uncomfortable place. That's what it was telling us. If we were going to be really open about race and discrimination, we were going to have to approach it system-wide. We couldn't just sort of put on a few modules and get a few people to do it and hope that they were going to change the culture of an entire organisation. It wasn't going to happen. So it was everybody's business, but particularly we needed optics at leadership level because everything's very, of course, it moves top down. But we also needed to reframe our thinking a little bit on it. You know, much like the way we give importance to safeguarding, which is absolutely vital. We accept there's no endpoint. We accept people will have to keep learning things and training. And we needed to take this approach here if we were going to start having conversations and think about development and training. And that's where we would see the biggest impact. So, Catherine, would you, thank you. And then we started to look at, well, what are other people doing around the system? So that was a bit of a sort of literature deep dive. And we had organisations like the Health Innovation Network in South London who made a commitment to actively be an anti-racist organisation. And that was on the back of the George Floyd murder and sort of pulse-checking things with their employees. And this is a really helpful diagram that they use in their their journey about becoming an anti-racist organisation. And they talk about, lots of us sit in the fear zone. So, it's really uncomfortable to talk about racism. I don't really necessarily want to get in those conversations, and actually it's nice to be comfortable. And then there's the learning zone you move to, which is, well, actually, I sort of acknowledge that racism is a problem. It does have an effect on people's health, physical health, mental health. Actually, I'm in a place where I'm going to start to have those conversations and sit in the uncomfortable. And then there's the growth zone, which is more around allyship, knowing how and when to speak out, knowing that we're not always going to get it right. And this was as much about, I think, us reflecting on this as a team ourselves and figuring out where we were and how we move across these zones, as well as thinking about, well, how do we encourage these conversations across our system? And can I have the next slide, please, Catherine? So, and if you don't mind clicking through them all, thank you. So we then started to think, well, hang on, there's great work happening in our system. We don't need to reinvent a wheel. There's lots of brilliant things happening around ethnic health inequity. I'm not doing it justice by those, by those organisations in that box. There's lots more. And what we said is, well, we need to collaborate better. We need to be a bit more cohesive. People are working in their pockets. And therefore, is there a place for something like a community of practice and a bit of a sharing and learning network, but that gives people the space to think about those zones we need to move through, have the uncomfortable conversations, because that's what's often not present when we're putting forward these interventions. And thinking around, well, what are anti-racist working principles? How do we embed them as business as usual? And it was really, if you click through the last bit, Catherine, thank you, and that was really probably how we were going to make any kind of real impact with decreasing ethnic health inequity. We were not going to do it if we just keep doing the front-ended interventions. So last January, we invited people across the system, public health, RBG, primary care, secondary care, voluntary sector, hospice. I'm going to miss people out, I'm not intending to, but we said, are you interested in this? Because we're interested in this. And we just need a starting point. Let's get together, let's talk about it. How are we going to achieve this? I won't read the whole slide, but this was essentially, a 3-hour get-together of us all thinking about it. And we asked two main questions. So what does it mean to be anti-racist in your system? And people told us all sorts of things. We needed to be non-judgmental, to have the ability to self-reflect, to be really curious, but also to understand things, again, that are uncomfortable. So what are people's experience of racism? Do we understand our own inherent biases and privileges? But one thing was really clear about all this feedback is everybody agreed that no action wasn't an option. And we need to figure out how to work better as a system. And the next slide just details, again, a bit more of the summary. So the second question we asked is, well, when you work as part of that system, what do you need to deliver your work in an anti-racist way? And we had people, who work in perhaps really small teams to people who work in huge systems. And they said, well, again, with the qualities, we need self-awareness and courage. We do need leadership buy-in. There is a role of training. We didn't quite understand whether we would play a role in that. That we were trying to change culture, so we needed to keep chipping away and accept it would take time, and make sure we take our communities with us and we collaborate really well. And if we move to the next slide, so that was January 2024. And then as a team, we came together and said, well, essentially, this is what people are telling us. That they wanted a space for sharing best practice, to have conversations about how we move that learning forward, be realistic, so some of the things we do don't work, but that's still really helpful to talk about, but also to share those challenges and those uncomfortable conversations, because people said, actually, I've never really been anywhere to an event where I'm sat there and we're talking about experiences of racism and discrimination, and that was really uncomfortable, but I learned a lot from it. and I haven't had that opportunity before. And again, the no action isn't an option. So that's where we were about a year and a half ago. And so as a team, we mopped all this up and we took it forward. And the next slide shows you what we've been doing in that time. So to respond to the sort of two core things, which is sharing of best practice across the system, but also give us a space to have those uncomfortable conversations. We split it into webinars that people can log on to at lunch. So the Health Innovation Network, who I mentioned, actually came and spoke to us about what they did about becoming an anti-racist organisation. We've had a talk from renal doctors and nurses who are doing some great work around kidney disease, offering spot tests for people, particularly from South Asian and Black Caribbean and Black African backgrounds in church halls and things like that. They're picking up great levels of unknown kidney disease. And we also had the Lewisham Refugee and Migrant Network coming and talking to us about the particular challenges those groups have in accessing healthcare. And then we turned our attention a little bit to the in-person. And with that, we had the event in January, and then in November, we had an expert facilitator who spoke to us about race-based stress and trauma. That was admittedly quite hard-hitting. I think we had a lot of conversations, which is one of our participants said, you know, we need to get comfortable with the uncomfortable. And, you know, I think we did really unroot things, and we're very, very conscious that, you know, we try to hold people within what we describe as a psychological container. I think we've moved away from saying psychologically safe, because as much as we'd love to do that, those conversations about racism are not safe. So we're kind of transparent with people. We invite them to come and we will support them during that, but we are also learning as a team. And Health Watch evaluated us this year, and then we ran a mop-up session in July for our team. And this is where we were before our Health Watch evaluation. So very broadly, we always evaluate our sessions. Our feedback was quite positive overall, but did as well tell us, you know, where we needed to think about things going forward. And that's where we got to. And I'm going to hand over to Catherine now, which takes us through from the Health Watch evaluation onwards.
Can I just check timings? How? Just looking at time. Are you all right? Is it all right for another 5 minutes? Yeah, great. And just want to acknowledge that. Yeah. Sorry, I kind of feel like I broke the. Just to acknowledge that obviously Joy is in the room as well, and was really important for taking forward this evaluation. And we found the Health Watch input very valuable. So I'll just pick up on a few things to do with the evaluation. Just here we can see the spread of organisations that have attended to date. We want that to expand though, particularly for the online activity. We just feel that the more the merrier. And actually, before I get into the evaluation, just to acknowledge that this is against a backdrop, certainly within the council, of huge strides with thinking around EDI generally, and equality and the equality objectives, and anti-racism work specifically. So one of the key things that came out of the evaluation further down the line is how we connect a bit more systematically to all those other big drivers. This is obviously not just for the council, this work, but you can see that many of the attendees are, and we're a large organisation. So there's that commitment on that join up, and I think there's a lot to learn from both strands of work. So the papers actually had quite a lot of this content in it, so I won't spend lots of time going through every single point that came out of the evaluation, but I'll just pick up on a few key bits really. For us, there was something about really clarifying the purpose. Some of the work that we were doing was veering into, it's very emotive. So there was lots of things being explored, and it was felt through the evaluation that we need to kind of come back and really pin down the purpose of this work compared to broad anti-racism work. So there's been, I'll show you the mission that was developed in a moment. We've mentioned this term around psychological safety is mentioned here, but that point about the container that you made is really key. And also that this can mean different things. So there's something about people feeling comfortable talking about the uncomfortable, but there are also processes and systems that can be set up to help people explore things that happen, particularly in the workplace. That's a whole other level of thinking about the psychological container. And that probably sits more with those broad organisational EDI aspirations, but that's an example of where we want to really connect in. Our vision for the future. Yeah, so here, for us, we felt it was really pinpointing opportunities to recognise the actions that people are taking as a result of what they're hearing and talking about and exploring. And that was a real ask from people to make space for thinking about their own actions to be anti-racism within their lives and their work. And then about how we're sustaining engagement. So there are aspirations about health equity work generally, and this definitely fits within that. So building resources and resource hubs for people to be able to centralise some of this and access things when they need to is a real key thing for sustaining engagement. But there's other points there about how we integrate into broader work streams. And just thinking about our reflections and impact, how we're measuring, so really pinning down what we're trying to do and then tracking how we're doing that, and encouraging others to do that too. This is just a bit of a reflection piece, so lots of positive things that I will let you just skim yourself, but also some specific points about measures and space for actions that have been reflected already. And then this is our draft mission, so I won't read everything, but that top line in bold, our anti-racism for health equity community of practice is a supportive dynamic space for sharing, learning, collective thinking and collaboration, and members are playing an active participatory role. There's an awful lot of thought put into the words and order of the words and rehashing, but that means that people are then really committed to this being the purpose, and we're committing to reminding people of the purpose every time we meet so that people understand the focus. I'm not going to focus too much on this, just to recognise that we've done some mapping around the anti-racism system, if you like. So that's internal council mapping, external facing, but also internal work happening in other organisations, and again, externally, and a bit of another. You can see there's quite a spread. So it's key for us to kind of keep an eye and connected to all of that. This is just acknowledging that you've had updates here about the annual public health report. This will very much sit within in that work. And then this is our forward plan for 25-26. One of the things that also came out of the evaluation is just being really organised and letting people know what we're doing throughout the year, when, where, and what. So we're very much committing to doing that going forward. Any final reflections, Nipa or Joy, or any questions? Thank you.
Just to really add to what's already been said, I think one of the sort of strongest themes that came out for us as part of the evaluation when speaking with officers and colleagues and members of the system that are taking part is how inspirational and forward-thinking, having that opportunity to come together and, as you say, trying to feel or get comfortable in that discomfort and really trying to work and support each other together to sort of move this agenda forward. So it was really, I think, a very sort of powerful reflections that we heard from those attending, and you know, our evaluation had lots of information in it, which I know that it's been acted on, but actually this is a fantastic model that absolutely could, I think, as you said, could really do with maybe having a bit more engagement from the system more widely, because there's a huge amount of learning that's gone on. There's a huge amount of support that's been given within the group, so others can try and take on those models and that learning as well. And I think this is something that, you know, absolutely would benefit from being rolled out much more widely, and having much more broader commitment amongst system partners for taking part and contributing. So.
Brilliant, thank you. No, really, really interesting. Yes, if we go to questions, Councillor Cairo.
My question would be around the timing, because we talk about the EDI agenda across the organisation and everybody working together. Is there a set timeline for yourself to work on a pace? Because if you look at the organisation itself, it's been, since 2021, we've been saying that we're going to be doing stuff around EDI and everyone's going to be working together. Now we're in 2025, still nothing really concrete that has come out as partners and organisation feeling that we have stepped forward to tackle this issue. So how are we going to measure this, that it's working, and at what pace?
Yeah, so from a council perspective, I think there's been huge strides with focus on EDI, and I think there's some EDI work coming to scrutiny fairly soon. So there's the EDI action plan, there's the Directorate's action plan. I know that there has Directorate's done a lot of work on that plan, so I really want people to be aware of that. But I think across the council as well, I know that there's the equity objectives and the action plan coming out of the EDI steering group that Florence Kroll chairs. So I think there's probably been a lot of activity there, and this happened as that was developing, but very much we are the people that are plugged into both of those things. So definitely we'll be kind of positioning that alongside it. So I think when it comes to tracking and measures, we've got that commitment to look at that in a bit more detail, but we want to do that within that broader context of the big EDI plans. So yeah, I think it's speeded up is hopefully what I'd say to you, but I don't know whether any other people involved in EDI would say any different or add anything to that.
Yeah, I think that's it's a really helpful question. One of the things that I think we were always keen to do with the COP is to make clear that it cuts across all systems. And that, in a way, is our strength. It's also a weakness, because when you cut across all systems, it then does become a bit harder to start measuring things. I think Health Watch have put us in a direction that's really helpful in terms of the measurables. So one of the things that came out quite strongly from our members is, where are you feeding back to leadership? Because this needs to be heard. And sometimes at the sessions, we don't always necessarily get the leadership quota we would like, because we also understand they're quite busy people. So one of the things that we did in that mapping was to make sure that within our team ourselves, because we also cut across the system, that we are feeding that back into those various spaces. The other thing that I would say about this, I think this is probably a complement to EDI, because I think it's quite well recognised that when we talk about anti-racism, it sometimes complements but sits slightly separately from standard, say, EDI training. It's a different kind of issue, but very related. And one of the challenges I came up against when I said, well, I think we need to set this up, there's a real gap. People say, well, how are you going to measure it? How can you feasibly measure if systems are less racist? And I said, well, realistically, we can't, because it's taken hundreds of years to get here, but that doesn't mean we don't do it. It doesn't mean we don't have the difficult conversations. So one of the things I'm always sort of quite careful about is being realistic with what is measurable with this, because we're not going out and doing lots of interventions, but we are very much going to support the people that are. But I feel like we're filling a gap for them that they don't get elsewhere, which is every so often to come into this space and be able to ask those questions and be facilitated by an expert, and to hold space for people to have that. I know in some ways that sounds very soft, but at the same time, I feel like we'd be doing everyone in our system a disservice if we didn't offer them that space, because I don't think we're going to manage to do that continuous learning if we won't address, well, where did it come from? And even though the people sat around that table will have no bearing in where that came from, it still exists. So if we don't know it exists, we can't do anything about it. So I think you're right. There's a lot of measurable things that we need to be doing, but there is a reality here that the COP does sit a bit differently to say a community blood pressure or the 100-day cardiovascular challenge that we did, which was very sort of driven, and here are the targets, which we absolutely still need to be doing as well alongside it.
I think you summed it up pretty perfectly. My reason I'm asking this question, because I know there's cross-cutting departments that needs to be coming over to deliver on this, and that is where the problem is. That's where the slowing the pace will always happen. And I know the EDI stuff around the RBG, because I've started it myself. It has not picked up at all. It stands still. But the work that is happening across health has always been at the forefront of this within the community and within the neighborhoods. But I just don't want it to, the rest of the system slowing you down. So if there is, things in the way, do let us know and we can try to open it up and speed it along.
You will always have a champion in Councillor Cara, for sure. And your response has kind of helped me a little bit more with my question I was trying to figure out in my head, because you talked more about, first of all, dual tracking, the things that you're not going to be able to measure, but work still needs to be done, alongside having those pilot project pieces, which can be really powerful, like the hypertension piece, if you're able to kind of show that. What I wanted to check, and you talked then also about how your job is to facilitate, potentially. You might have already done this. Are you already kind of presenting to VCS? Because in my head, we've got this health, this health inequalities, pot. There's so many amazing projects that the VCS could be suggesting for that, but inspired a little bit maybe by you and your group's intelligence and your work and your thinking. Could that kickstart some applications potentially that we could foster and support?
Yeah, I mean, I just to come back on the VCS point, I think that really connects to the broad health equity piece, and also our voluntary sector review piece of work that's kickstarting, and the voluntary sector grants and our relationship with the voluntary sector. So we've got lots of connections through commissioned arrangement grants and partnerships with the voluntary sector. So I think our aspiration is, yes, that we would want to absolutely be doing, bringing this conversation in more detail with the relationships that we have already. And I think that the launch of the APHR will allow us to think about the frameworks for doing that alongside the voluntary sector kind of review processes that are kickstarting.
The other one was great. The other follow-up question I had, which you semi-answered because I could see you had Lewisham Refugee Migrant Network in your plans, but just that Borough Sanctuary piece, I couldn't see Borough Sanctuary Network specifically in your mapping, so I would ask if you could bring those connections in. Plus, I think there could be a little bit of joint work potentially on, we did the joint strategic needs assessment for sanctuary seekers, but I think it would be good to kind of, can we bring that thinking together a little bit? Because I don't think we looked at, and I'm looking at Sam maybe to correct me if I'm wrong, I don't think we looked at kind of like, for example, looking at that mental health piece specifically for people that have had quite traumatic journeys here. Some aren't able to access mental health support due to their status. Then you've just got people dealing with that, trauma. I think that mental health piece, particularly with that sanctuary seeking part, it would be really interesting to kind of better understand that and see if we've kind of fully captured that in the JSNA. But yeah, thanks.
Yeah, we did some focus on sort of safer surgeries type activity, but I completely take your point. I think there's more to do with that connection generally about sanctuary seekers, so we'll do that.
Councillor Cara, sorry.
Thank you. As you mentioned, the VCS, I would always say not to forget faith organisations, because sometimes they sit outside the picture of VCS.
No,
and the only reason I'm saying that, there's a local pharmacy within our ward, within our borough actually, that has started a programme across one faith organisation and now is working across South London and brought 4 faith organisations across the whole of South London, and progressing really rapidly, doing blood pressure checks and all other stuff are coming after that. More stuff is, but I'm happy to share that information.
Yeah, thank you. Always mean faith sector as well. Sorry, I didn't explicitly say it, but yeah, I would like to hear more about the specifics. Thank you.
Can't see any more. No? Fantastic. Okay. I think But yeah, thank you very much. That was really, really great. Both separate items have been brilliant. Okay, so next, I think we've just got item 7. So we've got Health and Wellbeing Board for the work, basically the forward work plan that we've got. So our next meeting will be in December, and that meeting's scheduled for the 2nd of December. And we are bringing the addiction strategy forward, and that's going to be presented by the public health team. So it's a newly developed strategy, which will also be bringing in gambling for the first time, which so it's all together in one addiction strategy, but looking at kind of a support system, system-wide working and partners. So I think, again, a really good one that we're bringing here and kind of having that input. And I think that is everything. Any other business? None? Final thing to say is this will actually be Mark's last meeting. So I wanted to say thank you very much for Mark's contribution and for being part of the board. But yes, we're very sad to see you go. But yeah, thank you all. Have a lovely day. And we finished early. Brilliant. Thanks.